There. Okay.
There you go.
All right.
I'm going to let everybody in.
Sounds good.
We have 63 in the waiting room.
Mhm.
Welcome, welcome, welcome to Care Concierge with Carepatrol, where education is the heart of everything we do. We appreciate you being here and we appreciate your patience as the last month, due to technical issues on my part, we were unable to host any CEUs, so we appreciate those of you sticking with us. We have a wonderful presentation today. Dr. Sipma from UAB will present stroke management. And this is a new topic for us, one I look forward to. Dr. Sipma is a returning presenter who we always love to have. As you know, we're accredited by the Alabama Board of Social Work and also, or have in the past been also accredited by the Board of Nursing. We're reapplying for that status. But we are providing 1.0 contact hour today, and it is a live contact hour for social workers because we use a password protected evaluation. We give the password at the end, and then you are able to complete it and receive a certificate within 24 hours. The evaluation stays open tonight, and for those of you that are not at a screen and cannot see the chat room where I've posted this information, the link today for today's evaluation, which you must do in order to receive credit, is https colon forward slash forward slash www dot surveymonkey.com forward slash lowercase r forward slash all uppercase letters with numbers 8 G as in girl 7 T as in Tom X 22 excuse me X Z as in zoo 2. So Z as in zoo 2. That is the end of the link today. We'll give the password at the end. I've posted this in the chat room, and now we'll welcome Dr. Sipma to share with us a wonderful, I think, overview of stroke management. Thank you so much, Dr. Sipma, for being here. I know you have a lot on your plate, and we appreciate you lending time to us to provide this education.
Happy to be here again. Thank you for having me back. And I was telling Sean earlier, I was just getting off the hospital service last week, so we are seeing a lot of strokes. So for today's event here, we're going to be going through, let me get there, going over some of the types of strokes. We'll kind of go over the acute management as to what's happening in the hospital. So that way you're aware of kind of the ins and outs of what goes on there for the patients that you're encountering or family members who are affected by this. And then we'll talk to you about long term, what's the management once we get out of the hospital, where we kind of helping our patients recover as best we can. Again, lecture today is for educational purposes. So again, this is not meant to be medical management for anyone individual. That should be reviewed with your medical team. And then none of my ongoing studies have anything to do with stroke. So nothing that's relevant here today to disclose. So a little bit of background. Why are we talking about this topic, right? So strokes are very common. So about every 40 seconds, someone in the United States is having a stroke. And about every a little over 3 minutes, we have somebody dying from a stroke here. And we are in the stroke belt, as we call it. So as you can see on the purple map, that Alabama is very dark, meaning we have a very high age-adjusted prevalence of stroke in our state, as well as through most of the South. A lot of that has to do with just having higher risk factors in general as to the things that can lead to strokes being overweight, high blood pressure, diabetes. There is a bit higher risk for our African American patients for having strokes and having more disability from strokes as well. So it is very relevant. It's about one in every, I think it's 32 people ends up having a stroke in their lifetime. And then 1 in 4 will then have a second stroke after that. So very common throughout the United States, but especially here. And then looking specifically at Alabama, it is the fourth leading cause of death for patients. Even amongst those who have heart disease, again, common to have a stroke in addition to heart disease there as well. So kind of our number ones and our number 4 leading cause of death in the state. And so then some background as to what are we talking about here today, a little overview of, again, strokes are due to blood flow problems. The brain is very connected to the heart. We have those branches coming off of the aorta. So kind of on this right side picture here, you have the aorta at the very, very bottom, and then it splits into your internal carotids, which go up each side of the front part of the neck. Not well visualized is the back part where we have vertebral arteries as well. And then those all branch off into smaller and smaller vessels all throughout the brain here on both sides. So a lot of the strokes that we deal with are going to be kind of in that what we call anterior circulation, or those forward parts of the brain. The most common ones tend to be either these little small branching vessels, which are more prone to damage from things like high blood pressure and diabetes, and cholesterol problems. And then 2, just kind of based on where we get the branching off, kind of these more flat portions here are our MCA, our middle cerebral artery territory. And so those strokes tend to be fairly dramatic because it's covering a large area of that brain that you can see here in blue. So that's usually the ones we're seeing where someone's got a left, or like the half of the body, right? The arm is drooping, the face has got a little droop on the smile, the leg can't move quite as well, we're numb on one side. So that tends to be kind of in this middle cerebral artery territory, especially if there's speech problems too. That's going to be more on the left side of the brain, is the part of the brain that controls our ability to produce speech is more in the frontal areas. And then our ability to understand speech is more in our temporal lobes, but both are supplied by this area. So if you get a very, very large clot, we might have all of those trouble speaking, trouble moving, trouble with sensation. If you have a smaller clot where it goes into some of these smaller branches, you might have more isolated symptoms where it's just part of that, not the whole syndrome there. This anterior cerebral artery in purple kind of covers the frontal lobe and then the central parts of the brain. That tends to control more of like our foot movements, bladder control, some judgment areas. And then this green part here is what we call the posterior cerebral artery supply. So that comes off some of the back branches in the vasculature. And that occipital lobe is very involved in our vision. So a stroke there can present with, they can't see on half of the world. So if it's a right side stroke, then the left side of their vision drops out. They may not fully be aware of some of that. So we have to go through special testing on our exam to make sure they are actually seeing on both sides, because the brain tries to fill things in. And so you might not notice a more subtle change like that quite as rapidly as something like the whole body weakness. Other thing to note too is if we're getting the right parietal lobe, so in that right blue side here, parietal lobe is involved in attention to other things. So you can get some neglect, meaning they're not fully aware of their problems. So I've definitely had patients where they've got left side facial droop, some weakness, maybe some numbness, but because their brain isn't processing those things, they aren't fully aware of it on testing. So it's also very important to kind of be getting collaboration from family or from, again, pictures if they've got an obvious facial droop, kind of clarifying a little bit as to what time course are we dealing with, because the patient might not fully be aware of when things were normal versus when they started to be abnormal. So that's a little bit of basics on the brain. And so that's why, too, we talk about a mnemonic to try and help you kind of understand some of the big worrisome signs of strokes, but with the caveat of not every stroke is going to present the same way, right? Not every stroke is going to have all of these symptoms. It largely depends on which vessel is the one affected. So BFAST is the one that we've used nationally to kind of help people remember what are the signs of strokes. And again, strokes are very sudden onset. So this is we've got a blood clot, we've got lack of oxygen, things happen very, very quickly. This is not like like over 2 days we've been a little bit more confused and it's just gradually getting weaker. This is a sudden onset. We've got a either big rupture or a big blood clot that's being problematic. So anything sudden, we want to get evaluated as soon as possible. So whether it's balance, so that's lack of coordination, or dizziness, that's usually from some of the back parts of the brain. Eyes with blurred or double vision or loss of vision. Again, that can either be from the posterior aspect, or we can sometimes get clots just to the small vessels that are going to the eyeballs themselves, where we have a full loss of vision in one eye. And then face, right? So numbness, tingling, sensation, drooping on one side of the face. This can lead to some of the speech changes as well, where it's slurred speech or difficulty speaking because of a facial droop. Arm numbness, tingling, weakness on one side of the body. That applies to leg as well too, right? If we just can't move that leg quite as well. And then our T stands for time, because we want to call 911 immediately if we're seeing any of those signs. The faster we can get treatment, the more likely are to preserve some of the brain tissue that's at risk of damage. But if we're like, let's just sleep it off, wait till see if it goes away, we can have more permanent damage and not be at eligible for some of the interventions that we can do if it was an immediate response, an immediate presentation to the emergency department. So kind of going back to some of the basics here too. So how are we talking about strokes? What are those types? So the two main types we'll hear us talk about are ischemic and hemorrhagic. So ischemic is going to be, we've got a blockage of blood vessels preventing blood flow beyond that to the rest of the vasculature and the brain tissue. And we'll get into some of the types of those here a little bit later. The main one I want to highlight here is going to be a transient ischemic attack. So a transient ischemic attack, or TIA, is where we have those signs of a stroke, right? We have weakness or we have trouble speaking. But when we get to the hospital or shortly after there, within 24 hours, those signs all go away. And then we do an MRI of the brain, which is able to look for that damage of, did we have cells actually die? And we don't see any permanent damage with a TIA. These typically are going to be small vessels where that clot is able to break up on its own before we're causing some of that permanent damage. And then hemorrhagic strokes are going to be where we have a blood vessel that's rupturing, it's bleeding into the brain or the surrounding space. Both ischemic and hemorrhagic strokes, depending on where they are, can look very, very similar. Hemorrhagic tends to have a little bit more of a very severe headache with them, just because the blood is very irritating to the nerves on the meninges, which surround the brain. You can also get some headaches with ischemic strokes, but I find the more severe ones are typically with our hemorrhagic strokes at onset. And then again, kind of going a little bit more in details as to why those ischemic strokes each type happens. So our ischemic strokes in one of our studies called like our TOAST criteria, divided them up into a couple different etiologies or why they happen. So one of our big ones is going to be large artery atherosclerosis. So on this top middle picture, as you see this plaque building up over time, it narrows that area where we become a lot more thin. We can either have, again, the blood clotting up in this area because of that irregularity, or that atherosclerosis gets so tight where we just can't get the blood flow by it. Or this atherosclerosis sometimes too can break off and then send a piece of that atherosclerosis further down and into a smaller vessel where it's too big to let blood flow go by there. So large artery atherosclerosis is something that we're looking for on our vessel imaging, seeing if we're concerned about those maybe needing to get an intervention later. Cardioembolic, meaning there's a clot that's forming somewhere else, but usually it's in the heart, and then that clot is showered or thrown from the heart up those bigger vessels into some of those smaller vessels where it then gets stuck. So common causes of that are going to be things like atrial fibrillation can cause our left atria to be a little bit enlarged. We sometimes have a pocket forming where then blood can pool here and form little clots. And then as it gets moved through the flow, that gets shunted up those other vessels all the way up to the brain. Or if for some reason we've had a heart attack, so this larger part of the ventricle is not moving very well, we can have clots forming there, then breaking off and showering to other vessels, etc. Small vessel disease is going to be those little tiny, small, branching ones that are very, very sensitive to things like diabetes, high blood pressure, or sleep apnea, smoking, or just very, very high cholesterol. Because they're already smaller, they are more sensitive to things that are going to damage those vessel walls, either leading to kind of more blocking off there or little atherosclerosis that cuts off some of those blood vessels. And those are usually deeper. So those are going to be less of, it's not going to be presenting with all of those symptoms we talked about earlier of like the weakness and the speech problems and vision problems. It's going to be we have maybe just some isolated numbness or we have just some weakness because it hit a very, very small part of the brain, but it's in a deep area where all of our connections are going through. And so we still get symptoms on half of the body, but it may not be as extensive with the symptoms. Stroke of other determined causes, right? So there can be things like we don't have a full clot forming either locally in that vessel or coming from somewhere else, but we have a clot coming from like a broken leg can shower fat, which can land in the blood vessels there. We can have hypoperfusion, meaning we've got some narrowing, and then we had a drop in blood pressure, and now that area behind that narrowing was more at risk, and so didn't get blood flow for an extended period of time and had some damage occurring from it. Cancers are another thing that can cause some increased stickiness of the blood, and so we get strokes associated with cancers. And there's a number of other things here too. Vasospasm being like if we have irritation of the blood vessel, so it's not actually blocked, it just narrows and spasms tight or closed. And again, we can get some damage if that spasm and clamping down isn't resolved in a short period of time. And then cryptogenic stroke means we aren't sure what caused it yet. Again, that might just be we haven't done all of the workup quite yet, or even with the workup, we don't have a smoking gun in regards to what caused it necessarily. And so we want to still follow those patients and modify the risk factors we do know about for them. Right. And then switching over to hemorrhagic strokes a little bit on what different types those are. So you might hear epidural hemorrhage. So that's going to be like the second picture here where we've got an arterial rupture. So you have a very like lens-like showing like a collection of blood underneath some of the layers closer to the bone. Usually this is after trauma, which is hitting an artery right along those bones. Subdural is going to be bridging veins around the brain have ruptured and are slowly leaking into this space. And so it's got a longer, more crescent-like shape over a larger section of the brain. These can be a little slower to build up. Again, maybe after trauma, it tends to be our elderly patients have a little bit more shrinkage of the brain. And so then those veins are stretched a little bit more and can have some bleeding from those chronically. Subarachnoid picture I don't have demonstrated here on CT. That's blood getting in the space right around the brain. Some of these ventricles and these black spaces that you see on CT appear bright with new blood. Usually typically trauma, or these ones can be where we have an aneurysm, which is a little outpouching of the blood vessel, either that was formed for a genetic reason or in the setting of high blood pressure, some other vessel abnormality that lets that wall outpouch a little bit. That rupturing can lead to bleeding into those spaces. And then interparenchymal hemorrhages are on this far right side. And so those are bleeding into the brain tissue itself. Again, number of causes in this regard. People with Alzheimer's disease, their arteries are a little bit more prone to bleeding because of the protein depositions. People with an underlying metastatic cancer can have bleeding into the brain. A malformation between the artery and the veins that form kind of in growing up, an AVF or fistula, those can also then lead to some of these interparenchymal hemorrhages as well. So big things here are going to be our acute management, right? So when someone's rolling into the emergency department with weakness, numbness, vision loss, speech changes, something abruptly changed, we're trying to figure out what happened. How do we tell the difference between these bleeds and these ischemic strokes? So Providers are trying to get a history, figure out what symptoms are going on. And a big part of it too is going to be a last known well. So this is when was the patient last completely normal, verified by somebody else. That's if they're waking up with symptoms, then our last known well is before we went to bed. Sometimes that can be a, hey, no, like we woke up in the middle of the night, went to the bathroom, was able to walk fine, at 2 a.m., went back to bed, woke up at 6 a.m., and now I've got, weakness where I can't walk out of the bed. So that might be we can get a partial history, or that may not be fully when we went to bed, but maybe woke up in the middle of it. And this will come into play with our treatment options and interventions. And so it's important to clarify that right off the bat. Then we do a physical examination. So we do a stroke score. So it's a quick and dirty examination of, we're looking for big signs of ischemia that can tell us how big the stroke might be before we get to the scanner. And again, is this going to be a largely disabling stroke, or really we're not noticing much in the way of symptoms? And so it's going to be potentially either a smaller stroke or in an area where we've got some good collateral flow. And then we also look for our glucose and our blood pressure when someone first arrives. A very, very high glucose or a very, very low glucose can mimic a lot of neurologic changes. So you can have weakness, you can have speech changes or numbness just in the setting of sugar changes without any actual blood flow problems to the brain. And then basic labs too get sent off right off the bat. They aren't immediately back, but we want to know what our coagulation status is and some of our basic electrolytes, because that'll help when we're trying to discuss options for patients. And then you go to the CT scanner as quick as we can get you there safely. So this is looking for those bleeds like we saw on some of those past pictures. Bright things are going to be the bone around the skull, as well as any acute blood is going to look very, very bright. So that's going to change our management of it. If it's hemorrhagic, we start down one treatment pathway. If there's no blood, then we start talking other treatment options. We also, if possible, not all hospitals have a CT, which can do a perfusion scan, but this can look at which area is already damaged where we're not going to be able to save it, kind of these purpley pink areas over here, compared to the area that's at risk of dying. And so if we've got a large mismatch, so we've got only a little bit that's dead, but a large area at risk, that can say, hey, we might want to intervene on this, versus if we've got a large area that's already died and not a whole lot more than that that's going to be saved if we do intervene on breaking up a clot in that area. That can help kind of inform our decision process on which stuff we'd offer to that patient and family. And then with this as well, as long as the kidneys don't have any problems with contrast, we'll try and get our blood vessel imaging. Because we're looking for, again, is there a large clot that we can see in some of those vessels? Or again, if there's a bleed, is there evidence of an aneurysm or a malformation or something that we can discuss with the neurosurgeons about? So we've got our CT head. We've now decided it's an ischemic stroke. We don't see any bleeding on that image. So those patients we're going to tend to let have a higher blood pressure, because the higher blood pressure in the setting of an ischemic stroke is trying to force blood into that area that's not getting the good blood flow. So we don't want to drop their pressures too quickly and cause more damage. And then the discussion becomes, are you a candidate for one of our clot busting medications? So we've got TPA or TNK. These are ones that are enzymes that'll help break down the clot that's formed there. Again, we want to make sure this was a relatively recent stroke. There's evidence that if we wait for longer than 4.5 hours since our last known well, we're at more risk of bleeding into that area and more damage to that brain area than saving it. And so we want a last known well within the last 4.5 hours. We're going to look for any contraindications, because this is not going to just break up the clot that's in the brain that we're worried about. It can also break up other clots throughout the body. So if we've had a recent GI bleed where we aren't going to be able to control the bleeding there, we've had another recent stroke or a major surgery in the last little while, that's going to be fairly dangerous with our risk of bleeding being too high. Again, talking about is their blood pressure well managed? Are they pregnant? Have they had anything else which might be a risk for them to have more bad outcomes from the bleeding as opposed to benefit from this clot busting medication? And then two, we aren't just going to give it to everyone we suspect has a stroke. If you are coming in and we have very, very minimal symptoms of like, I've got just a little bit of tingling in my hand, the risk of complications from that medication probably not going to be worth the potential risks there. So benefits versus risk. If it's not clearly disabling, we'll have that discussion, and we probably wouldn't recommend it for a patient with very, very mild symptoms. And then again, looking at that vessel imaging, is there a large clot that the neurosurgeons may be able to retrieve? That's kind of a picture on this side of they can go in through the leg all the way up and in through the heart to those arteries. And if it's in one of those larger branches, they can send a catheter, some tools where we push past the clot, open things up, and then remove that clot and pull it all the way out of the body, opening up that blood flow again to the brain. This we can do a little longer. We usually will be within the 24 hours, as long as one, we've got a good, reasonable CT perfusion where we're not going to damage things a little bit more for very little benefit. And again, it's got to be in one of those bigger areas where we can get a catheter in. If it's too far down, we're probably not going to be able to get into that space without damaging those blood vessels further. So that's compared to a hemorrhagic stroke, where rather than keeping a high blood pressure, now we're focusing on trying to lower the blood pressure because we don't want that high arterial spray into those areas that are already bleeding. We want to try and reduce the further hemorrhage as best we can. And then evaluating for the cause of the bleeding, right? Why did this happen? Is there a vessel that needs to be coiled or clipped, like in these top pictures over there? Is there a blood thinner that they're on that needs to be reversed? Right? There's some medications that can be reversed. People with really low platelets, or if they're on warfarin, we might talk about giving them a transfusion to give them a little bit more clotting products in order to try and help produce a clot to help reduce further damage from the ongoing bleeding there. The other things too, these ones tend to have a bigger risk of complications very, very early on, because if we still have that blood expanding, the space within the skull is a closed area. And so you can get very high pressure within the brain and get more complications from that increased pressure very, very quickly. So we're monitoring closely to see, do we need to go in and do a neurosurgical intervention, something like taking off part of the bone to relieve some of the pressure, or cutting just a hole in and putting a drain so that way we can take off some of the either fluid or drain the blood in that area, kind of talk about ways to help this patient through that immediate emergency situation so that way we can get things under control and back on the more medical management safe side of things. So hemorrhagic strokes can go downhill very, very quickly, and so are a little bit more emergent or life-threatening in that initial period. Compared to the ischemic strokes, where the swelling, the damage that can happen from these or a bleed into that ischemic area typically is going to occurring a little bit later in the course. So we still monitor both very closely, but hemorrhages can go bad very, very fast in that initial setting. And so again, the peak swelling for an ischemic stroke or after injury is going to be in the 3 to 5 days afterwards. And so those first 24 hours are important for, can we do anything emergently? And then those next couple of days are we want to make sure we don't do more damage from the swelling pushing on the brainstem, which can cause trouble breathing, loss of consciousness, permanent deficits, or death from that swelling. So usually those patients at high risk, we have nursing assessments every hour, maybe every 2 hours. For patients who are not very responsive, we're very reliant on our reflexes. So how are the pupils looking? Where are the eyes at? Are they having a cough or a gag if they're intubated and on any sedation? A little easier for patients who are moving around, talking with you. If there's an abrupt change, then we're going to again repeat our quick CT imaging and talk about with the primary team about next steps for them. MRI brain usually is done kind of in not the CT emergency room situation, but we do want it during that admission to better assess what extent of damage did we have done. There are some patients where, again, we do have some ischemia, but it's a small area. We've rebounded. We don't have a whole lot in the way of symptoms. And that can be helpful in kind of talking about, like, we did have a stroke, not a TIA. So we do need to do the stroke management for that. And then two, with those larger areas, we can see if there's any little bits of blood that we can't see on a CT scan, since the MRI is a little bit more detailed. Again, can look for, is there an underlying cancer that bled? Is there something else that we can pick up on this MRI, which we couldn't get just from the grainy CT that's in the emergency setting? And then big things here too are looking for, why did we have that stroke in the first place? And how do we prevent one from happening further down the road? So things like labs are going to be our A1C, our lipid panel, and we're looking for specific goals for those if a patient has had a stroke. Generally, if we don't have any other problems, our LDL goal is less than 100. But now that if you had a stroke, we tighten that goal further, as that's going to be our main risk factor for that atherosclerosis buildup, that gunk along the vessels. So we want to be a little bit more aggressive with our management there. And then these next parts are also looking for, do we have one of these other cardioembolic causes, right? We're going to have you on a heart monitor when you're inpatient, potentially send you out on a heart monitor for 30 days outpatient. Atrial fibrillation is something that can come and go, but if you have any episodes of it, you're at higher risk of developing those clots, which are going to potentially go to the brain and cause more strokes. And so that factors into which long-term medication the doctors are going to recommend. Same with the echocardiogram. We're looking for, again, is there any wall motion abnormalities, any shunt where we've got a hole in the heart that just didn't close up when we were born, where now a clot that's in the legs and the veins can go up and cross over and get up into the brain from there. Again, if we see narrowing in those larger vessels, we're going to talk with, do we need a carotid ultrasound to get a little bit more of a better picture of how much flow is going through that space or not. And then usually your first line is going to be an aspirin and a statin, unless there's some contraindication as to why you can't get either of those. If on our workup we find something that's going to be more prone to blood clotting, like the AFib, the heart failure, or some cancer that's ongoing and is going to be treated in long term, we might discuss doing anticoagulation instead of the aspirin. And then again, if we've got any sort of stent in the heart or in the vessels for treatment of narrowing, then we might talk about doing 2 antiplatelets with an aspirin and a Plavix. But again, a lot of that long-term discussion depends on those workup things that we're doing here. The other big thing too is going to be rehabilitation, right? So assessing the inpatient as soon as medically stable, especially for a swallow study, because big complication you can have is if we're not able to swallow correctly, we get a pneumonia, stay in the hospital for longer and get septic, and then have further complications there. So temporarily, patients might need to have an adjusted diet or have a NG tube to help with the feeding. And then multidisciplinary, so physical therapy, occupational therapy, speech therapy, looking at what are our deficits and how bad are they, right? Is this something where this is going to be life-altering? This patient who is living independently cannot go home now because they can't take care of themselves? Or is this something that, we can probably live with independently? We're just going to need a little bit more outpatient therapy to help get over this. Speech therapy too is not just with the swallowing, it's also with our speaking, our comprehension, what things cognitively are we going to need to do to kind of retrain the brain. Our biggest improvement after a stroke is going to be in the days to about 3 months following a stroke. So again, like if it's a TIA or very, very small one, some patients may rebound very quickly and we have next to no deficits leaving the hospital. But the patients with the large area of the stroke, it's going to be a lot more time in order to see our maximum recovery. And then brains are a little bit different here too. It depends on your level of function before coming into the hospital. If it's a young patient, your ability to kind of retrain those neurons, rewire the brain after an injury tends to go a little bit easier than an older patient who's had lots of tiny chronic strokes. And so we already have a fairly high level of disease burden prior to having this larger stroke. Caveat being our younger patients don't have a whole lot of brain shrinkage beforehand. So that swelling, those bleeding, the things that can cause increased pressure within the skull can be a little bit more life-threatening for them. So again, they're having more problems in the acute term, but maybe long term a little bit better. And then our older patients, because you've got more of that shrinkage over time with the brain, we have a little bit more space. So it's a little more forgiving if we do have a bleed or have some swelling where we may not need to take off part of that bone or do something a little more aggressive in the inpatient setting. But in the outpatient setting, it's going to be a little bit more prolonged for those older patients. And so this is going to be where our rehabilitation assessment comes into. So physical medicine rehabilitation, we've gotten a unit here that does that. And then there's other acute rehabs throughout the state as well, right? So is this someone who's going to be very disabled if we don't maximize their therapy, doing it every single day for hours to try and get them back to a functional baseline and able to go home? And that leads us kind of more into our long-term management. So first off, talking about secondary stroke prevention, right? We now have had a stroke. 1 in 4 is going to be at risk of having another stroke in their lifetime. The highest risk of that is within the first year after you've had a stroke. And so we want to do our best to try and prevent any further damage happening to the brain. So again, you're going to be either on an antiplatelet or an anticoagulation, kind of in collaboration with the stroke team, the cardiology team, the primary physician, kind of discussing what's our risk of clots versus our risk of bleeding. Again, we usually don't do too many or both of those at the same time because your risk of bleeding becomes higher if we're on more things that thin the blood or prevent some of those clots from happening. So again, if we know we're going for surgery soon, or if we know we already are prone to GI bleeding because of ulcers, that's going to be okay, what's this bleeding risk compared to their clot risk? If their clot risk is on the lower side, maybe we hold off on some of these medications. That's a very individualized discussion for every single patient. Then we said management of atherosclerosis, right? So that's going to be where our cholesterol medication comes into play. Most of the time, we're just going to be starting with the medication. But it might be to a severe point where we've already got a lot of that narrowing, we've got a lot of gunk, and it's flicking up parts of that plaque from the neck to the side of the brain that it's on. So then we would discuss with the vascular team, whether the neurosurgeons or the cardiovascular team, as to do we need to do a procedure where we go in and either clean out that plaque by kind of like scraping it out, or do they put in a stent? So that's a kind of wire mesh that helps open up that area. So that way we don't have as much stuff limiting our blood flow to the rest of the brain there. Again, if it's on that carotid ultrasound, we've only got about 50% of narrowing. We'll probably just do the medication management and talk about just keeping an eye on it. Versus if it's like a 90% where we've already got a lot of narrowing, we might discuss, do we do that inpatient versus a couple months later down the road when things have healed up a little bit more, depending on the size of everything and other risk factors. Again, our small vessel disease is largely going to be affected by our high blood pressure, our diabetes, some of our other risk factors too, right? So if we've got an ongoing cancer or heart failure or other things, we're going to be working with our outpatient providers to, on a multidisciplinary level, to manage all of those as best we can. And then with cardiology as well, talking about if we've got atrial fibrillation, do we need an ablation where they go in and try and prevent some of the more irritable areas from misfiring electrically? Or there's this Watchman procedure, which has been developed in these last few years, where again, that area in the atrium that kind of enlarges and can be more prone to those blood clots, they have a little device where they go in and they stick it in that area and it helps kind of clot that off so we don't have a pouch where we're more prone to getting that blood pooling, those clots from forming. Again, not an immediate sort of discussion that we're having in the inpatient, but that can be a long-term discussion of like, hey, this patient's very high risk from bleeding on the anticoagulation. If we get a Watchman, can we maybe come off that blood thinner and be a little bit safer overall for them? Same if we've got a shunt or we've got a hole in the heart, a PFO, and we know we've got blood clots down in the legs or from cancer or something else that's kind of causing that. Do we need a filter in the vena cava, which catches all of those before they get to the heart? Do we need a process to close up the hole in the heart, et cetera? So a lot of multidisciplinary discussion as to those sorts of things. Sleep apnea, another big risk factor for strokes. There's some studies that say maybe about 60% more likely to have a stroke if you've got untreated sleep apnea. So that's assessed by a sleep study looking for snoring for these episodes where our breathing stops. When breathing stops in the middle of the night, that affects a lot of different things, not just our risk for strokes. You can have increase in your blood sugars, increase in your blood pressures, worsening cognition because you're not getting good blood flow and oxygenation to the brain during those times. And so again, very damaging to small vessels as well as interacting with other risk factors, which are important for our long-term management. As well as things like, again, sleep apnea can affect things like headache, your weight, hormones, a bunch of other things can be affected by it. So overall, good to be assessing for that in the long term. And then cessation of tobacco is actually more effective than any medication I can prescribe for reduction in atherosclerosis and saving those blood vessels from further damage. So if anyone's smoking even a little bit, we are trying to get them to stop to whatever degree they can. Again, a lot of patients are a little hesitant about it, but again, it makes more of a difference than anything else we can do for those patients. Same with alcohol and illicit drugs. So things that like cocaine, methamphetamines, those raise our blood pressures a very large degree, which then damages all those small vessels. As well as having the metabolic changes with the alcohol, where again, we're just more prone to damage to the walls of those or build up in those vessels. And so talking with our patients about what are the things they're struggling with, how do we cut back getting them off of that as best we can is super important as well. And regular exercise, right? So this is not just important for the rehabilitation, but also for keeping the rest of the brain healthy. A big risk factor for strokes and a lot of our neurodegenerative diseases is aging. We don't have a way to slow aging, but exercise is the best thing we've got to kind of reduce some of that damage that builds up over time to the brain and the vessels. And best exercise is the one they're going to do, right? So encouraging them of like, hey, if we can't do this other exercise you're used to, running, maybe we'll modify to swimming or biking or something else that's going to be manageable for you in this time frame. Looks different from age group to age group, right? What you did in your 20s is not going to be necessarily the same thing you're doing in your 80s. There's exceptions, right? There's still these like ultramarathoners or Ironmans who are doing the same things much, much later, but kind of giving more manageable expectations or realistic expectations to patients is important there as well. And then talking about diet, right? A lot of our group down here is overweight and we do not have the healthiest of diet. We've got a lot of processed foods, a lot of very fatty foods. And so, especially if they've got high weight or diabetes, working with a nutritionist of what are some simple swaps? What are some little changes that we can do to make a big difference? Most patients are not going to do well with an all or nothing sort of approach, right? So it's not going to be we're getting rid of all the red meat or all your fried food. It's talking about what are little swaps. Can we incorporate some white meat maybe more frequently throughout the week? Or instead of, the fries at one meal, we're swapping that out for a salad with some veggies. And again, trying to stay away from maybe those chips or more processed things and swapping it out with a whole fruit or a whole veggie or something that's more identifiable without as many of those chemicals too, which can have a long-term effect on it. And then again, multidisciplinary care for the rehabilitation and dealing with a long-term disability from strokes. Because it's not just the weakness, it's not just the trouble speaking. There's a lot of other things that can be seen long-term after strokes. So again, dysphagia in that acute setting as well as long-term runs us the risk of aspirations. And so again, infections, pneumonia, things that wind us up back in the hospital. Talking about, do we need a peg tube to help just bypass the stomach for the time being? And as we recover, then we get back to using those oral intakes as previously. Educating the patient and the support giver too, right? Of like, these things you're going through, it's not you being crazy. There can be expected with stroke. It's important for you to let your team know if these things are happening so that we can address them. Again, emphasizing that recovery is possible, but it's not always quick, right? So these symptoms come on out of the blue. They come in like lightning. They're sudden onset. Wish recovery was as quick, but it is typically not. It's going to be a long-term ongoing physical therapy, occupational therapy, and speech therapy to work on the weakness. If they're developing spasticity in the affected limbs, do we need to address those with other medications from either PM&R, neurology, or primary care? Depression, also quite common, up to about a third of patients might have depression because, again, big life change where they're healthy, working, doing everything like normal, and now dealing with these long-term complications. So medications for depression can be quite useful for those patients. Um, Certain parts of the brain too can produce pain. So if you get a thalamic stroke, it used to be numbness when you first presented, and a couple months down the road, as things are trying to rewire, now it's misfiring and showing like very burning pain, shocking pain, things that are very difficult to live with and might need management with some neuropathic pain medications. Cognitive impairment too, we can see kind of this build up of like a vascular dementia. So it's different than the person who's got Alzheimer, where there's a protein that's building up over time and creating this cognitive impairment where they can't care for themselves or interact as well as they used to. With strokes, it's this little buildup of we've got either large strokes in very important areas, or in the connecting areas in those small vessels, we've got just a buildup of insult after insult where now those important communications just aren't happening throughout the brain. And so we have more of a stepwise progression of I was doing fine, had a big drop off, and then now at a new baseline, another big drop off with the stroke, and kind of more of a sequential worsening of cognition. Again, sometimes we'll try our medications that we sometimes use in Alzheimer's and other dementia symptoms. Response is kind of a little bit more variable for those patients. And working with speech therapy then is kind of more of an approach of how do we keep things wiring or rewiring or try to improve that as best we can. And then the other thing here too, epilepsy, right? So epilepsy, we'll talk about here the next time I come to talk with you in a little bit more detail, but that is seizures happening. Those are abnormal electrical activity occurring from misfirings within the brain. Those in adults usually happen once we've got scarring occurring within the brain. That can be trauma. Stroke is then our leading cause of kind of adult onset epilepsies. Other scarring though too, again, like if we had a surgery and now have scarring, or traumatic brain injuries, et cetera. But again, stroke now can be a focus of this area that now is weak on the side of the body. Now we've got more rhythmic jerking, loss of sensation or eye deviation. That can be signs of now we've also got abnormal electrical activity coming from that stroke bed, which is causing more dysfunction. So it's on the rarer side in regards to possible complications and disability overall from stroke, but it's not zero. That's still 2 to 8%. So can be a decent number of our patients now dealing with that on top of, again, these other disabilities. So again, multidisciplinary approach, a lot of different long-term things. As social workers too, that's going to be then helping patients through this. Do we need caregiver support? Do they need respite care because now wife or husband is caring for this patient, where they used to be fully independent and functional? Or do we need some short-term disability because they might be able to get back to work to some more reduced capacity, but we're going to need accommodations. We need some way of supporting ourselves through that gap in that time when we're trying to recover, trying to get better. And again, insurance coverage for things like physical therapy, occupational therapy, speech therapy, got better coverage in those acute settings. But again, these patients recover over 12 months, 18 months. So getting that access to them long term is also oftentimes where we're seeing some of those gaps in care where things can be a little bit more optimized. And again, extra level of emotional support, right, as they're dealing with depression, as caregivers are dealing with adjustments and having to figure out juggling their own work or their own needs or medical problems, and dealing with patients is also a very big way that you can impact their overall care as well. And I think those are going to be the big things there. Other resources I want to highlight for you guys as well. American Stroke Association, American Stroke Foundation, great places too for people where they can get plugged into support groups, either for patients who've had strokes, or caregivers of people who've had strokes, or if we're looking for more reliable sources of information, these are going to be some of the ones that have good summaries of our recent studies, our recommendations as to which treatments are most recommended for people, et cetera. And again, very, very common problem. So They can be very disabling, potentially deadly. So I want to make sure everyone's aware of what to look for and knowing that seeking care immediately is going to be our best way to help prevent some of this long-term disability and potentially death from strokes. And they can be either ischemic where we have lack of blood flow or hemorrhagic where we've got bleeding into the brain. And then again, 1 in 4 patients is going to have a second stroke. So it's important that they stay in the hospital so that we can assess what are our risks, how do we modify those things, how do we send you out on the right medications to keep this from happening, right? It might be a very small stroke to begin with, but then we're coming back with a large, life-threatening, devastating stroke the second time around. And then two, early and ongoing rehabilitation is going to be our best way to maximize our recovery so we have as little disability as possible from a stroke and can get back to doing the things we love doing, potentially working again or working in a different type of capacity, or again, just being able to maintain independence and stay out of a nursing home or where we want to be long term is going to be kind of those goals that we're focusing on. So I think we've got a little bit of time here for questions. Again, tried to keep it broad overview, but the most important things for you guys to be aware of here as you're helping patients and family navigate these things.
So please ask your questions via the chat room if you will do so. And then I have a question, Dr. Sipma, which is,
Yes.
Would you share your slides so that I can forward them to the attendees?
Yes, happy to share those with you.
Terrific. Thank you so much for really thorough discussion. And I know the slides will be helpful to those as they look back over today's course. It doesn't appear that we have any questions, but I will read again the evaluation link, which will be open until 8:30 tonight to accommodate you. You must do the evaluation to get a certificate, which will go out after the evaluation closes. The evaluation link is https:// www.surveymonkey.com/r/ all uppercase letters and numbers 8 G as in girl 7 T as in Tom X Z as in zoo 2. That is our evaluation link, and our password is management with a capital M, lowercase ANAGEMENT. Management is the password for today's evaluation. Dr. Sipma, there's so many comments. I hope you're seeing them of people thanking you and letting you know what an excellent presentation today was. We always enjoy having you with us and look forward to you joining us again this year. I'll share the link again per someone's request in the chat room. It's https://www.surveymonkey.com/r/8 G as in girl 7 T as in Tom X Z as in zoo 2. That is the evaluation link. The password is management. Dr. Sipma, thank you. Do you have any closing remarks?
Again, thanks for having me again. Again, stroke's very common, so happy to always educate a little bit more on what to look for and trying to get it in to see us as soon as possible for these big life-changing sorts of things. And appreciate all your guys' work too, caring for our patients. It makes a big, big difference.
Thank you for your work, and thank you again for today. Y'all have a great couple of weeks. We'll be back on Tuesday, April 7th, with UAB's Dr. Caitlin Rosginski, who will be presenting hydrocephalus on Tuesday, April 7th. Make sure you sign up for that. And if you miss a presentation that you want to see, remember we leave these or post these rather onto YouTube where you can take them for credit. So if you have questions about that, let me know. Thank you again to everyone. Thank you for the work that you do. Thank you, Dr. Sipma. Y'all have a great couple of weeks, and we'll see you soon.